You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 5th, 2021. This week, COVID, screening for carotid disease, Subcutaneous ICDs, alcohol and AFib, and rent-seeking in medical education. Now first, COVID. My review of the Johns Hopkins site this week reveals continued good news. Cases are on a steep decline. In the US, California, and in the EU, and even in Portugal, cases are coming down. Every day, too, more and more people receive vaccines. And on social media, you no longer risk cancellation if you mention the term herd immunity. These are all good signs. Still, though, I was in the ICU this week, and I asked the nurses how the COVID situation was going. And a nurse who was donning her PPE responded, "It's like Groundhog Day." What I took from her words and her look on her face was, get out of here with your optimism. I'll believe it when I see it. When historians tell the story of this pandemic, I hope the ICU and emergency department nurses and support staff get some serious recognition. It's really impossible to pass them in the hallway or cafeteria and not feel a sort of reverence towards people who work in these units like every single day. Second topic is carotid screening. In 1968, Doctors Wilson and Younger wrote this about screening in their book, Principles and Practice of Screening for Disease. Quote, "The object of screening for disease is to discover those among the apparently well who are in fact suffering from disease. In theory, therefore, screening is an admirable method of combating disease. In practice, there are snags." Yes, they actually wrote the word snags. This week, the United States Preventative Services Task Force, the USPSTF, has reaffirmed its recommendation against screening for asymptomatic carotid stenosis. Why? Why would that be? I mean, stroke is a leading cause of death and disability, and billions of dollars are spent treating stroke. It must be a good thing to find those blockages in the neck before they lead to stroke. But the task force based their recommendation against looking at carotids on the evidence that the harms outweigh the benefits. In other words, the snags. Now, before I tell you about the snags, we should say a word about the USPSTF. These are an independent volunteer group of national experts in prevention and evidence-based medicine. 16 members come from all different aspects of behavioral medicine, family medicine, geriatrics, internal medicine, etc. And I went through their conflicts of interest and I saw no relationships with industry. Now to the issues at hand. Snag number one. First is the scope of the problem of carotid stenosis. One way to assess this is using something that's clumsily called population attributable risk, or PAR. That is, the number or proportion of cases, here stroke cases, that would not occur if the risk factor would be eliminated. The population attributable risk depends on two things: the prevalence of the risk factor and the strength of its association with that disease. The prevalence of asymptomatic carotid disease in adults is kind of tricky to find. One study shows about 0.9%. Now you contrast that with hypertension, which is super prevalent. So the population attributable risk for stroke with carotid artery stenosis is about 0.7%. The population attributable risk for hypertension is 95%, for smoking 12 to 14%, and for high lipids about 9%. So right there you see the issue. Even if there was a perfect way to treat asymptomatic carotid disease, you would have very little effect on stroke rates in the population. And If you just think about it, stroke comes from many, many different factors, and the carotid arteries are just one. Now, snag number 2. The evidence that carotid endarterectomy or surgery improves outcomes over medical therapy is dubious. The ACAS, ACST, and VACS trials, these were the seminal trials comparing carotid endarterectomy to medical therapy, were done nearly 2 decades ago. The risk reduction with surgery in these trials was about 2% in absolute terms, an NNT of 50. Now, the problem with applying these trials now is A, the trials were done in centers with experienced surgeons, and given the tiny amount of benefit, even the slightest tick up in surgical complications would eliminate any net benefit. B, medical management has surely improved over the 2 decades. We now have high-potency statins. For instance, in the ACAS trial, the best medical management was aspirin, stop smoking, and take your blood pressure pills. And in the ACST trial, less than half of patients were on statins. Dr. Stephen Spence's group in Canada has a paper showing that the risk of stroke at the time of a 100% carotid occlusion has been reduced over time. Remember, the brain, even more so than the heart, has built-in collateral vessels. As journalist Sue Hughes points out in her coverage of the USPSTF story, there are now 2 ongoing RCTs looking at interventional approaches versus meds in patients without symptoms. That's good news. Now, snag number 3. The data for carotid intervention with stents does not look any better than surgery. In fact, I looked at a Cochrane review of 22 trials involving nearly 10,000 patients that found that perioperative strokes are higher for stenting, and this tilts the balance in favor of carotid endarterectomy versus carotid stenting. Snag number 4 are the risks of testing. Let's consider what a positive test means. Now, I can cite a systematic review that estimates the sensitivity and specificity of color Doppler ultrasound for a carotid lesion greater than 70% at about 90 and 94% respectively, which sounds good. All right, now let's take a higher incidence of 5% of asymptomatic carotid disease in the population. What are the chances of having a disease if you have a positive test? Now remember, medical tests don't usually tell you if you have a disease. They only update your baseline chances. And here comes Bayes' theorem again. I love Bayes' theorem. So the chance of having the disease after a positive test is the base rate chance of having the disease times the Bayes factor or likelihood ratio. So the likelihood ratio is the sensitivity, the chance of having a positive test if you have carotid artery disease, divided by 1 minus the specificity or the false positive rate. So in this case, it'd be 90% divided by 6. That's 15. So now you have a base rate of about 5%, which again is probably an overestimate. 5% prevalence is a 5 out of 95 odds ratio. You multiply that times the Bayes factor, which you just figured out is 15. And now the odds are 75 over 95. And that translates to a probability of having disease after a positive test of only 44%. Pause on that for a second. The average patient being screened for carotid artery disease, therefore, is more likely to have a false positive than a true positive. Now think about all that can happen with either a true positive or a false positive. If the patient gets operated on for a true positive, there are the risks of surgery, stroke being the biggest. If the patient is falsely sent to the doctor, there are costs and risks of downstream testing. A contrast reaction from a CT scan, for instance, or personal bankruptcy from the slew of downstream testing. Snag number 5. Now, we might argue, come on, Mandrola, if we detect disease, we can get the patient started on statins and lifestyle therapy. That's a good thing. Well, the problem with that logic is that all patients can decrease their risk of vascular disease with lifestyle changes, and nearly all high-risk patients that have disease discovered would have been high enough risk via a simple pooled cohort equation to recommend statins in the first place. So in sum, my friends, screening asymptomatic people for anything is an intervention. If you think it is beneficial, theoretical advantages are not enough. given the potential cost and harms of this test and intervention, you have to prove that the benefits of this through randomization. Until then, the United States Preventative Services Task Force is spot on, and don't screen for asymptomatic people for carotid disease. Next topic is about the subcutaneous ICD and recent recalls. The U.S. Food and Drug Administration has issued a Class 1 recall of the lead used in the subcutaneous ICD. Let's first go over some basics of ICDs. An ICD is a simple device designed to decrease the risk of death by detecting and shocking ventricular arrhythmias. Now, the standard or transvenous kind of ICD involves putting a lead into the veins and then the heart. This lead inside the heart can then pace and sense and defibrillate the heart. Numerous, highly convincing randomized controlled trials of these transvenous ICDs show that when they're used in selected patients, they save lives relative to medical therapy. The Achilles heel, however, of these devices are that the leads don't last forever. They can fracture. That can cause oversensing and painful, inappropriate shocks. Leads can also get infected, and this can be an utter disaster because A, it often leads to bloodborne infection and/or endocarditis. And B, if the leads have been in place for years and get infected, removal can be a very high-risk extraction procedure, as over time, leads tend to scar in place. Enter the sub-Q device, which avoids the risk of having leads in the blood and the heart. The sub-Q device, the generator sits in the left mid-axillary area, and the lead is outside the chest wall, close enough to the heart to sense and shock the patient out of VT or VF. But not having leads in the heart comes with the downsides of not being able to pace the heart, as well as having to use higher energy to defibrillate the heart. Some very early studies, very small studies, have suggested that over time, the energy required to defibrillate the heart with a sub-Q ICD may sometimes exceed the output of the device, and obviously this is a big problem. Now, I know what you're thinking. Surely, John, since the outcome of interest here is death, they have done proper trials comparing standard transvenous devices to sub-Q devices, and the two are equivalent over the long term. Well, no, not really. I've recently reported on the Praetorian trial, which seemed like a fair comparison, but it was clearly not. For one, the median follow-up of Praetorian was only 4 years, but the concern about transvenous leads is not over 4 years, it's over 10 or more years. For another problem, Praetorian used a non-inferiority design and counted outcomes that everyone knew would go in opposite directions. Remember, in non-inferiority trials, no difference is a positive outcome. So if you count outcomes that are going in opposite directions, say efficacy and safety, you bias towards finding non-inferiority. Now back to the FDA recall. Such a lead failure, they write, could prevent the device from delivering shocks as needed. This applies to about 20,000 devices manufactured from March of 2016 to November of 2020. Now, if you were a medical conservative and a slow adopter of new technology, you don't have many of these patients. If you were an early adopter, you have a bigger problem on your hands. After practicing in EP for 2 decades, and after practicing through the very horrible Medtronic Sprint Fidelis lead situation, I have been solidly in the slow adopting camp when it comes to putting hardware in people. All medical device companies will have recalls. It's part of the risks of the device. And I also suspect that someday subcutaneous technology will be better than it is now, but I'm not sure we're there yet. Next topic is alcohol and AFib. Now, in the early days of my training, we called it holiday heart. That is the association with high-dose alcohol intake and AF. Now, numerous observational studies have shown an association between lower doses of alcohol intake and AF. The relationship seems to be somewhat linear in that the more alcohol one takes, the more the risk of AFib. A very nice study recently by Alex Voskobonic, when he was in Melbourne, Australia, found that in patients with AF, abstinence from alcohol significantly reduced AF burden. But why is this? What's going on? The UCSF EP group, led by Drs. Greg Marcus and Ed Gerstenfeld, have published a small but elegant study which provides some potential clues as to the mechanisms of this relationship. They randomized 100 patients who were undergoing AF ablation to either an IV alcohol infusion versus a placebo infusion. They then measured refractory periods and conduction velocity in the right, left atrium, and pulmonary veins. And they found that pulmonary vein effective refractory periods decreased on average by 12 milliseconds, and in the alcohol group with no change in the placebo group, and the difference was statistically significant. They didn't really find any other differences. Refractory periods and conduction times in other areas in the left atrium and overall in the right atrium did not differ, and AF inducibility also did not differ. Now, these observations suggest that alcohol exerts direct and acute EP effects that may render the atrium and particularly the pulmonary veins more susceptible to PVs. Remember, the pulmonary veins have long been known to be an important driver of AFib. That's why we target them during ablation. And having a shorter effective refractory period is arrhythmogenic. This is because it increases the excitable gap in which re-entry can occur. Now remember, the mechanism of action of many antiarrhythmic drugs is actually to decrease the effective refractory period. Having a shorter ERP in the pulmonary veins may be especially important for the genesis of AFib. I was surprised that the only significant finding was ERP changes in the PVs. There was no change in conduction velocity, no change in ERPs elsewhere. Perhaps this was because the authors kept the dose at the legal limit of alcohol. Perhaps a bit higher dose would have changed more of the parameters. It's also possible that a type 2 error was there and that randomizing more patients would have allowed them to see other changes. But I think this is really nifty experiment because it links a clear and modifiable association of alcohol and AFib to a putative mechanism of getting AFib. And I say kudos to the UCSF team. The final topic today is about medical education and specifically the ending of the clinical skills exam for fourth-year medical students. The first thing to say is there's little good about the pandemic. We'd surely be better without it. But it's here, and it will usher in some positive changes. Now, one of these changes seems to be the abrupt cancellation of the Step 2 clinical skills exam that's given to fourth-year U.S. medical students. Now, sometimes my fellow colleagues in medicine shock me in their soft thinking. Here's what the testers thought was a good idea. Hire a model patient, a paid actor, to simulate a model disease. Grin, as if this ever happens in real life, ever. Then, make medical students travel on their own dime to one of only 5 sites in the U.S. Five sites in the entire U.S. Charge the medical students $1,300 to take this test. Then, it won't matter if the student can't hear the cardiac murmur. She or he only has to put the stethoscope in the appropriate 4 quadrants on the chest. For nearly 2 decades, this utter folly and rent-seeking behavior from colleagues was just another paid-to-play scheme for U.S. medical students. And by rent-seeking, I mean the practice of manipulating a policy as a strategy for increasing profits. Medical education is full up with rent-seeking. Well, then the pandemic came, and in-person exams were unsuitable. What did the rent-seekers do? They abruptly and permanently canceled the exam. The testers now say clinical reasoning and communication skills will be able to be assessed in other steps. Of course they can be. They've always been able to be assessed in other steps. Medical schools teach and assess these skills. So do internship and residency. But if people would only tell the truth, the real truth, they would say it takes years of being a non-hobbyist, real clinical practitioner to master doctoring. And even then, medicine will continue to humble you on a regular basis. Now, I've never had to take this Step 2 exam, but I'm glad it's gone. The larger lesson, though, transcends fourth-year medical students to the silliness of many of these testing schemes. The ABIM MOC program comes to mind. Here you have another group of hobbyist doctors who seek to extract money from working doctors in the name of quality. I say fine if you can show me any independent evidence that it improves outcomes, but there is none. I would say fine if you did not grandfather in older doctors, who actually would be the most important people to test. And I would say fine if you required APRNs and PAs, who are now increasingly independent to undergo the same testing. One of my hopes is that someday I will see doctors get together and advocate for our profession. It's unlikely to happen, but if it did, we'd be a lot less susceptible to these rent-seeking bureaucracies. So that's it for this week in cardiology. As always, I'm grateful that you listen. Thank you. And remember, friends, if you like this podcast, it really helps if you take the time to give us a rating, write us a little review. It helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.